York Region, as I've mentioned before, we truly value this partnership within CIFL York. And we collectively acknowledge, of course, the importance of bringing these experts to you to build capacity in our communities through the speaker series. As a public health nurse myself, I work in the area of built environment, and I do support improving community health and well-being, preventing transportation-related injuries, and of course, as others, reducing health inequities. So this Transportation Equity and Justice series, it provides a space for sharing experience, knowledge, and discussing how equity and justice issues and considerations are addressed in transportation. And I'd also just like to mention, I had the good fortune of having Linda Rothman speak with us at York Region before with our Active and Safe Routes to School work. So of course, supporting that transportation equity piece with children prior as well, and early on in her research and sharing her work. On behalf of CIFL York, we hope you do enjoy the session, and we invite you to engage during the Q&A so that you can continue the conversation. Thank you and welcome, everybody.
Thanks a lot, Tia. And now I would like to introduce Dr. Alison Macpherson, professor at School of Kinesiology and Health Science, Faculty of Health at York University. Professor Alison is also an adjunct senior scientist at the Institute of Clinical Evaluative Science, a member of LaMarche Institute for Child and Youth Health, and a member of the editorial board of the journal Injury Prevention, and has kindly accepted to be moderating today's session. Thank you, Dr. Alison. Now over to you for starting off the session.
Great. Thank you very much, Shireen. It's my pleasure to be here and be surrounded by my three wonderful colleagues who are going to, I think, provide some really interesting presentations. The first person who's going to share her thoughts with us is Dr. Linda Rothman, who is an assistant professor at Toronto Metropolitan University. Take it away, Linda.
Thank you for the introduction. And Tia, it seems like a really long time ago that I was with your group up in York Region. So I'm happy to be here again. I'm just going to share my screen. And everybody can see it? Okay, great. I'm going to talk to you today about social inequities in child active transportation injury. And as was mentioned, this has kind of evolved over time. At the beginning of when I first started working on this research, we weren't so much focused on inequities, but this has become more and more apparent that this is a huge issue in our communities. Again, I just wanted to emphasize, I'm at Toronto Metropolitan University. For those of you who are not familiar with that name, that was formerly Ryerson University. That's our new name as of a couple months ago. I'm also an adjunct scientist at Sick Kids and assistant professor at the De La Luna School of Public Health at U of T. And I'm very honored to say I did my postdoctoral fellowship at York University under Dr. McPherson. The first thing I want to emphasize, and I'm sure you've all heard this before, is that we have to focus on the fact that injuries are not accidents and that injuries are preventable. They're predictable and the result of many different factors. We have seen significant reductions in road traffic injury, morbidity, and mortality in Canada over the past 20 years. However, though, we still have thousands of Canadians who are still injured and die from road traffic injury every year. And this is not just a Canadian problem, it's worldwide. I do want to emphasize, and my colleagues all know this, that injury is a severely underfunded and understudied area of public health, and we are desperately trying to change that within the Canadian context. Just a bit of perspective. This is from the Global Burden of Disease Study from 2019, and these are fatalities or deaths in Canada for kids ages 5 to 14 and ages 10 to 24 on the right-hand side. Road injury in the 5 to 14-year-olds causes 14% of deaths in Canada. And in the 10 to 24-year-old age group, so that's young adults and adolescents, it's 21%. So it is a major cause of fatality within our young people in Canada. This is from the City of Toronto. This is over time from 2012 to 2022 with our COVID-19 pandemic kind of stuck in the middle there, or over to the right side there. The blue is pedestrians, the light The next little green is cyclists, and the top is motorcyclists. We don't tend to focus on motorcyclists. We're more concerned with our vulnerable road users, especially for children. Now, again, this is not children specific, it's all ages. But basically, pedestrians and cyclists made up 61% of all fatalities in 2012, and it's basically the same in 2021. So things haven't gotten better. We do see a little dip in COVID-19 because people aren't moving around anymore. There's more and more evidence that cycling and pedestrian volumes have gone up since the pandemic because a lot of people are more focused on moving around in that way and less, especially with the new gas prices with cars. So we are carefully monitoring trends on what's happening with collision rates and are desperately trying to figure out ways to prevent our increased volumes in cyclists and pedestrians resulting in more collisions. Why have we had such little progress in terms of our active transportation, and that's cycling, pedestrian collisions over time? We know that our cities in Canada have been built primarily focused for cars. There's issues on distracted driving. We've got more cars and larger cars on our roads, higher vehicle speeds as time goes on. As I mentioned previously, we've been seeing more walkers and cyclists, so more exposure on our roadways, and the COVID-19 pandemic has influenced this quite a bit. But what I really want to focus on today are the equity issues regarding who's walking and cycling and what's happening in terms of collisions, because we do know that there are equity issues that I'm going to talk to you a little bit more about. A paper that we did a little while ago was looking at pedestrian emergency department visit rates in Ontario for 0 to 19-year-olds. And what we saw from 2008 to 2015 is that the emergency department visits decreased overall by 18%. However, when you looked at it by income quintile, so the dark blue are the lowest income quintile, the white is the highest income quintile, you can actually see that over time, the rates have gone up in low income groups and gone down in the high income groups. And overall, the highest income quintile had a 48% lower rate. So there are huge inequities in who's showing up to emergency departments in terms of collisions by socioeconomic status. We've also done quite a few studies looking at active school transportation, so AST, and collisions over time. We've done a lot of observational data collection in 2011, 2015, 16, 18, 19. Overall, this is focused on right now on the city of Toronto. There was 251 schools we did observations at with over 107,000 children counted. And what I mean by counted is we had observers standing outside of schools, counting how kids were arriving to school, whether it was by car, by foot, or by cycling, and examining the proportion of kids using active transportation to show up to schools. We also looked at police reported pedestrian collisions around schools in relationship to this. And I do want to emphasize that some of the later data collection was part of our Child Active Transportation Safety Environment Study, or CHASE, we're going to refer it to in the subsequent presentations. And my co-presenters will be talking more about this study, where we looked at these kind of things, not just in Toronto, but in other cities in Canada, Vancouver, Calgary, Surrey, Montreal, Laval, and Peel region. Okay, so again, my co-presenters will be talking a bit more about this later on. In terms of the range in active school transportation, we saw huge ranges in the city of Toronto. Some schools, there was only 28% of kids showing up by active transportation, the rest were being driven. And some schools had 98%. And you can see the light blue are the lower ranges and the dark blue is the higher ranges. Why does this happen? And those are the kind of things we wanted to explore with some of our research. Also, huge range in collisions. Why are there more collisions around some schools and less collisions around other schools? So this is what a lot of our research has focused on over the years. But again, this presentation is about equity. So what I wanted to show you here is we found that greater school disadvantage was associated with higher collision rates, higher density multifamily housing, higher speed roadways, less traffic calming and more traffic congestion. And higher active school transportation was associated with lower socioeconomic status, primary language not being English, recent immigration, and visible minorities. So you can see that these groups are walking or probably walking to school more, and that may there's a relationship with higher collision rates. So, can the built environment or the environment around schools help reduce social inequities in, first of all, the active school transportation? And we looked at 105 schools in 2017 and 2018. And we found that proportion of recent immigration was consistently related to more active school transportation. I do want to show you the graph on the right, or the chart on the right, is an example of some of the findings that we got from the study. We looked at walk score. So how friendly was the environment to walking around the schools? And this one is an example of material deprivation. So on the left side, the vertical axis, you're looking at what proportion of students were arriving by active school transportation. And across the bottom is material deprivation. So the lower levels are higher income. So this is so they're less materially deprived. And the higher end here is the more materially deprived. The green across here is high walk score. It's great walking conditions. The purple across the bottom is low walk score. You can see where the walking environment is great, that there's no difference between low and high income groups or material deprivation groups. So where things are good, lots of kids are walking. Where things aren't so good in terms of the walkability of the environment, more of the materially deprived kids are walking, with less of the higher income kids not walking or walking. So, can the built environment help reduce social inequalities in active school transportation? So by ensuring that all neighborhoods are walkable, we can result in children with higher deprivation walking in safer and more walkable environments, whereas children with less deprivation will also enjoy the benefits of active transportation. They are not walking in the walkable environment. So that's a really important finding, is that the built environment can reduce social inequalities in active school transportation. And this is a brand new study that we just got published actually this week. Now we're going to look at the collisions. We do know from lots of other studies that we've done as a group together that the roadway built environment interventions are very effective in reducing injuries. More speed humps is associated with less injuries. Cycle tracks are very protective in terms of cycling collisions. Reducing speed limits reduces collisions. And a study we did a while ago on streetcar right of way that separates pedestrians from streetcars also is very predictive of pedestrian incidents. If we change the street design, it shifts some of the responsibility from the individual road user and avoids blaming the victim, and it benefits the community as a whole. So not just the kids, it can benefit everybody, including seniors, which also have huge issues in terms of pedestrian collisions. One of our studies that we looked at a while ago is we looked at high and low income clusters in the city. And we have, if you look at the dark parts of this map, these are high child pedestrian motor vehicle collisions. The lighters are low. The high income clusters are outlined in blue, and the low income clusters are outlined in red. And you can see there's a lot more darker areas within the red lower income areas. And we found that collision rates were almost 6 times higher in the low income clusters. Then we decided to look at speed humps, which we know are effective from some of our research. Again, low income is red, high income is blue, and the speed humps are with the burgundy lines. And we found that there are much more speed humps put into these higher income neighborhoods. Okay. There's 4 times lower densities of speed humps in low income clusters. There was also lower densities of low speed roads, so more high speed roads in low income clusters. So again, we're talking not only about inequity in terms of where the collisions are happening, but where we are actually putting in effective interventions, which is really, really important. When we looked at the social factors and pedestrian collisions in children, alongside with some of the built environment variables, we found that higher material deprivation and higher densities of recent immigration was associated with more collisions in children. Again, we know that past evidence that traffic calming is effective in reducing collision, but why isn't this showing up in these as being protective in terms of pedestrian collisions in children? Let's look at this map. This map is particularly interesting for the York University area. These are the dark red are hotspots. These are child pedestrian collisions, 1 to 17-year-old. You can see there's a hotspot up by York University. There's also hotspots in other areas in the city. Blue is cold spots. So we're going to focus on the hotspots. So Jane and Finch, Yonge and Eglinton, because of all the LRT construction. We've got some other areas that are lower income areas like Thorncliffe Park and Regent Park that are hotspots, pedestrian collisions. Then you put on our Ontario marginalization deprivation score. Again, lower income, more material deprivation up in this area, where there tend to be more pedestrian collisions. Where are the speed humps? Downtown Toronto, kind of cold spotty. That might be showing that it's effective, but it's also showing that we are not putting effective interventions in the areas that need them the most. Why is that? Well, I do, before we talk about why, I do want to point out one other thing. We did a recent map, which has not been published or anything yet, that we found really interesting, is when we looked at police reported pedestrian collisions before the pandemic. So on 2016 to 2020, and we kind of went part way into the beginning of the pandemic. The hotspot pedestrian collision was down here. And look, we're getting an emergence of hotspots after the COVID-19 pandemic started up in the northwest part of the city again. And there's all sorts of conversation going on about why this is happening. Are people here tending to be using more active transportation because they're essential workers? There's all sorts of things that we could look at in terms of that. But we do want to recognize that there's an emerging hotspot up in the northwest part of the city. Why do we have more traffic calming in higher income areas? And the process of request favors those with higher socioeconomic status. It's not an equitable method of identifying need. So basically, if you ask for, you have to ask for traffic calming studies to be done. So people who are better connected, know the political processes, tend to get the traffic calming. We do need more objective methods of determining need. We need to look at the number of collisions, where the collisions are happening, higher speed roadways, things like that, in order to have a more equitable way of putting in effective road safety interventions. So can the built environment help reduce social inequalities and collisions? Yes, absolutely, but we need to implement built environment changes where they are actually needed, not just in areas where people ask for them. Just briefly, I want to talk, present the Vision Zero idea, which we adopted in Toronto in 2017, and that many North American cities are now adopting. As many of us know, the goal of Vision Zero is to reduce killed and serious injury collision. It removes the responsibility of road safety from the individual and focuses on the transportation system. So we're more focused on the built environment and the environmental changes rather than individual behavior. It has to be data-driven, as I spoke before, not just request-based. We have to look at evidence-based interventions. But as time goes on, there's more and more recognition that Vision Zero has to have more of a social justice and equity lens. So we do have some issues regarding our Vision Zero data gaps, and it's something that I want you to think about and take away with. We don't know much about how many people are actually using active transportation. We have very poor, non-existent walking and cycling data. What is happening up in the northwest part of the city? How many people are actually walking and cycling up in that area? Why aren't there any cycle tracks up in that area of the city? Who's using the AT, active transportation? Where are they using it? Also, we have really poor collision data. The police reported data underreports collisions. We know they do better with fatalities and the more serious injuries, but we don't have good records in terms of minor injuries. Hospitalization data doesn't have location, and it can be inconsistent in terms of availability of care. We don't really know really well who is actually being hit, which is really important. So we do really need to focus on these data gaps and improve them with our new Vision Zero Road Safety Plan. So to conclude, more walking and cycling in our cities does not have to result in greater number of injuries. Built environment and Vision Zero changes makes a difference in Canadian cities, but is needed now more than ever. And the goal is to emerge from the COVID-19 pandemic with cities that are much safer for walking and cycling for everyone. Thank you very much.
Thank you very much. I think, Shireen, correct me if I'm wrong, but we hold the questions till after all three presentations are done, correct?
Yeah, that's correct. We can all get the questions at the end. Thanks.
Perfect. Thank you. So thank you, Dr. Rothman. Now it's my pleasure to introduce Dr. Emily McCullough, who is a postdoctoral fellow working on the CHASE study and with myself and Dr. Richmond. So take it away, Dr. McCullough.
Great. Can everyone hear me all right? Wonderful. Thank you, Allison, for that kind introduction. Before I begin, I'd just like to acknowledge my privilege and positionality as a white, Western, and Global North researcher who uses she, her pronouns and is cisgendered. So the title of my presentation is Road Safety, Health Equity, and the Built Environment, Lessons from Transport and Injury Prevention Professionals in 5 Canadian municipalities. The results I will be sharing with you today are from a pan-Canadian project examining the role of the built environment in active transportation rates, as well as the disproportionate risk experienced by vulnerable road users, or more specifically, road users who are made vulnerable by the current built environment. So this project wouldn't have been possible without the hard work of this pan-Canadian research team. As you can see, it's quite robust. The generosity of numerous partners, and the support of the Canadian Institutes of Health Research, University of Calgary, York University, Sick Kids Research Institute, and Parachute. So I will begin with an overview of the project from which these data are derived, a summary of the methods and analysis procedures, and then examples from the data in the form of qualitative excerpts. So as I noted, these results are from one objective of a larger study that focused on the links between active transportation and the built environment. The study is supported by CHASE, a Canadian nonprofit organization that is dedicated to creating healthier and more sustainable communities. The third objective of this study aimed to identify implementation strategies for built environment change at the municipal level to encourage active transportation. More specifically, the goal of this objective was to better understand the barriers and facilitators associated with making BE changes that promote road safety and active travel. To answer this question, this research prioritized the experiences of professionals working in the fields of road safety and injury prevention in 5 Canadian municipalities: Vancouver, Calgary, Peel Region, Toronto, and Montreal. A significant finding of this work is that these professionals discuss barriers and facilitators to built environment change, specifically with regards to accessibility and health equity. So the links between the built environment and people's health are well established. Unfortunately, the current design of many built environments contribute to increased health risks for children, as Dr. Rothman explained, older adults, and other road users made vulnerable by the built environment. It is important to emphasize, once again, that these groups are not inherently vulnerable, but instead are made vulnerable by the current design of the built environment. Thus, modifications to the built environment can enhance the safety of vulnerable road users by decreasing crash incidents and mediating driver error, while density, connectivity, and walkability can increase the built environment's accessibility. However, built environment modifications are not implemented equally across communities, which highlights the importance of examining built environment change through the lens of health equity. Broadly, implementing health equity means pursuing the elimination of disparities and inequalities for people occupying a variety of social locations. The World Health Organization asserts health as a human right and defines equity as the absence of unfair, avoidable, or remedial differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically by other dimensions of inequality. Further, according to the National Collaborating Center for the Determinants of Health, health equity means that all people can reach their full health potential without disadvantage due to social position or other socially determined circumstance, such as ability, age, culture, ethnicity, family status, gender, language, race, religion, sex, social class, or socioeconomic status. Given the links between the built environment and people's health, it is imperative that we employ a health equity lens to highlight the disparities for equity deserving groups. Qualitative data were collected by members of the research team in each municipality. Participants were recruited from municipal, transportation, police services, public health, nonprofit, school and school boards, community associations, and private sectors. The research team used a combination of snowball and purposeful sampling techniques to recruit participants. Key informant interviews were conducted with participants in each municipality between January to December 2019, and virtual focus groups were held between July to November 2020. The original intention was to hold in-person focus groups. However, due to COVID-19 restrictions, focus groups were conducted virtually and used a third-party platform called Upwards to facilitate online discussion. Thematic analysis was used to code and organize the data, which is a useful approach for identifying patterns and themes in reference to the research question, what are the barriers and facilitators to built environment change? Further, thematic analysis enabled us to see patterns across the data regarding barriers and facilitators in relation to accessibility, health equity, and the built environment. Participants discussed barriers and facilitators in relation to accessibility and health equity concerns. Major barriers included exacerbated risk for marginalized groups and inequities in the built environment change process. Major facilitators included strategies for inclusive consultation and equitable BE changes. For the remainder of the presentation, I will provide some examples of data excerpts from participants across municipalities and sectors that illustrate these themes. Risks for marginalized groups. Participants identified accessibility and health equity concerns they encountered in their work. For example, a participant from Peel Region's public health sector explained, "We know that vulnerable populations such as school-age children, seniors, and lower SES are disproportionately impacted by a built environment that does not support health and safety. Improving the built environment should have more benefits for vulnerable populations because it's an attempt to reduce health inequities." Further, a participant from Calgary's transportation sector stated, "Safe means more than freedom from collision-induced physical harm. It is an unfortunate reality that people in our society are targets of physical and emotional abuse as a result of their gender, sexual orientation, race, and social class. And cars can provide protection from risks other than being hit by another car. These data illustrate an awareness of how pre-existing vulnerabilities intersect and are exacerbated by the current design of the built environment. It also highlights the privilege of motor vehicle travel with regards to safety. Participants provided examples of specific vulnerable groups and how their health is impacted by the current built environment. For example, a participant from Vancouver's public health sector addressed concerns for people with low socioeconomic status. In neighborhoods that have the lowest economic status, the infrastructure is poor. There was lower prevalence of sidewalks or separation for traffic speeds. Traffic speeds are often higher. There was more industrial than commercial traffic, and the crosswalks are not as good or signalized. In addition, a participant from Calgary's nonprofit sector identified concerns regarding the lack of built environment changes in neighborhoods with new Canadians and immigrants. Communities that have a higher portion of new Canadians or have a higher proportion of people experiencing low incomes, we know that they tend to be underserved when it comes to active transportation infrastructure. Participants also discussed concerns regarding the health and safety of older adults and children, women and caregivers, and people with disabilities. These concerns centered on the design of the built environment, particularly with regards to adequate lighting, walkability, and connectivity. Inequities in the BE change process. Participants discussed the built environment change process and how communities can meaningfully contribute to the design and location of desired changes in their neighborhoods. However, traditional approaches to community consultation, such as the complaints process and open houses, are not accessible for all. For example, a participant from Vancouver's public health sector explained how the city prioritizes BE changes. A lot of it is complaints driven. So if there is a community where they have the capacity to complain or the knowledge on how to complain, they can get elevated. But of course, that favors economic, more socially privileged groups. And evidence shows that those are the ones with the lower risk of injury. Once again, aligning with Dr. Rothman's previous presentation. In addition, a participant from Calgary's nonprofit sector commented on the inadequacies of the open house strategy for community consultation. This model of having open houses and expecting people to come to you is a waste of time. You're always going to get the same people, which is not representative. Overall, participants were critical of traditional consultation methods, specifically because they are not accessible for all road user groups, especially those already experiencing disproportionate health risks due to the current design of the built environment. So moving on to facilitators, strategies for inclusive consultation. Recognizing the inadequacies of current consultation strategies, participants discussed some more inclusive options. For example, a university researcher from Vancouver explained, it might have to look differently for different communities. It's not a one-size-fits-all approach. In some communities, you're not going to get anybody out to a public forum. You're not going to get any meaningful feedback. So you have to actually know what would be most meaningful for that community by having multiple pathway points for access. Maybe it's social media, maybe it's public forums, or maybe it's a community event. It's got to be diverse, and it has got to be grounded in the community. This illustrates the importance of not only changing the built environment according to the particular needs of communities, but the consultation process must also be adapted to suit the needs of equity-deserving road users. A participant from Montreal's nonprofit sector described their approach to inclusive consultation. Our approach puts users at the heart of the process to ensure that they have a voice in decision-making. This does not mean that all opinions and ideas are necessarily equal or considered. However, this method promotes dialogue between the parties, encourages empathy exercises, and often allows participants to better understand the position of others, especially the most vulnerable, and the decisions that are made. Finally, a participant from Vancouver's transportation sector explained the importance of inclusive consultation processes for equity deserving groups. Rather than just asking for more consultation, asking for consultation from specific groups who are not hearing and then elevating those voices when they do speak up. This would give us direction to put consultation funding to these groups and ensure those who do take the time to step forward that they will be heard. This is an example of a more inclusive consultation strategy that aligns with the health equity approach. Equitable VE changes. So participants also identified changes to the built environment that would promote health equity and access for equity deserving road users. For example, a participant from Toronto School Board sector noted the importance of connected pedestrian networks, ensuring that sidewalks don't end abruptly. While a policymaker from Montreal listed auditory signals, the installation of tactile paving stones, and reconfiguring the geometry of intersections as necessary built environment changes that would enhance the safety of vulnerable road users. Lastly, a Peel Region participant from the public health sector stated, ensuring there is lighting along the pathway or walkway to transit stops to encourage users to feel safe and use a pathway regardless of the time of day. I will conclude with a brief discussion and some key takeaways gleaned from this research. The results from this study provides insight from Canadian transport and injury prevention professionals regarding the need for built environment changes that serve equity deserving groups. Further, employing a health equity lens heightens concerns regarding the current state of the built environment and the processes that guide change. Some key takeaways include: 1, the current design of the built environment contributes to the disproportionate health risks for vulnerable road user groups. 2, it is important to include equity deserving groups and communities in built environment change processes. 3, traditional consultation strategies, such as the complaints process or open houses, are not accessible for many equity deserving groups. 4, there is an urgent need for a shift in the built environment change consultation process to ensure that equity deserving groups are well served by the changes. And 5, a health equity approach to consultation strategies is grounded in the understanding of the values, identities, lived experiences of equity deserving groups, as well as the economic, social, and political context. Overall, the concerns and strategies highlighted by this research ought to inform decisions regarding built environment change. When considering the implications for health equity and the well-being of all road users, change going forward is pivotal. Just briefly, a limitation of the study is that purposeful and snowball sampling techniques may have resulted in more similar views and opinions about the barriers and facilitators to BE change across municipalities and sectors, as opposed to random selection. In addition, the semi-structured interviews were conducted by different members of the team in each region, and thus the probing questions varied and elicited slightly different responses from participants. Lastly, the positionality of each interviewer may have affected participants' responses. I have a list of references I'm happy to share, and I am very grateful for this opportunity. Thank you for your time.
Thank you so much, Emily. Always insightful. Thank you. So moving along, I'd like to introduce Dr. Sarah Richmond from Public Health Ontario and also from the Dalla Lana School of Public Health. So take it away, Dr. Richmond.
Thanks, Allison. I'm just going to share my screen. Can you see that?
Yes, that's good now.
Okay, wonderful. Thank you so much for the opportunity to present today. As Allison mentioned, I am the injury prevention lead at Public Health Ontario. So I'll be presenting from the perspective of public health. So thinking of ways in which we do the work that we do to promote health equity and to program planning for road safety. A big thank you to the research team that contributed particularly to the data that I'll be sharing at the end of this presentation. It's a little excerpt of data hot off the presses from Emily's work that she previously presented from a public health perspective. So a big thank you to the research team, particularly Dr. Allison McPherson and Dr. Emily McCullough. A quick agenda for what I will be presenting over the next few slides is a bit of background on injuries in Canada due to motor vehicle collisions, as well as those specifically in Ontario. Public health practice for road safety in the province of Ontario in the context of the Ontario Public Health Standards specific to the Injury Prevention Guideline and the newly introduced Health Equity Guideline. I will be ending the presentation again by showing some data that is specific to public health practitioners or serves the perspectives from public health practitioners from the Chase Grant, as well as other public health practitioners from units across Ontario on built environment change specifically, and then to end this presentation with some key messages. So very quickly, some background in road safety. So injuries and deaths from motor vehicle collisions pose a very significant public health problem. In 2019 in Canada, there were over 100,000 motor vehicle collisions, of which 1,623 were fatal. In Ontario, when we look at ED visits and hospitalizations, these are data from 2020. There were over 60,000 ED visits due to collisions in the province of Ontario. And of those, 6,163 Ontarians were hospitalized. As you can see with this map of public health units, these are the public health units in Ontario, of which currently there are 34. These are ED visits, or the rate of ED visits due to motor vehicle collisions across the public health units. And you can see there's quite a significant variability in the rate of ED visits across PHUs. However, we're still understanding what factors contribute most significantly to this difference, despite knowing there are several risk factors in the previous literature that identify an increased risk for collisions, including speed and drink driving, as mentioned previously in Linda's presentation. However, what is less known, and despite the wonderful work of Dr. Rothman, the relationship between the social determinants of health, such as income, education, and other SES variables, and collision risk is largely unknown. Further, and arguably more concerning, is what's demonstrated here in the trends over time of the rate of ED visits due to motor vehicle collisions from 2011 to 2020 appears to be relatively stable, despite what appears to be a slight decrease in the rate of ED visits in 2020, of course, largely due to, or maybe 100% due to the pandemic. We see a dip in 2020. However, these rates remain relatively stable over time. This tells us that current measures in place may not be sufficient to address the high number of injuries due to collisions, which we know, and as we advocate for as injury prevention researchers and practitioners, is an entirely preventable event. This issue is further exacerbated when we consider the social determinants of health as factors that increase the risk for injury. We know there is a disproportionate risk for those in less advantaged populations. And this is documented as far back as the 70s and early 1980s with the publishing of the Public Health Report in England that identified a strong socioeconomic gradient between child pedestrian fatalities, particularly in levels of SES, where children from areas of low SES were 5 times more likely to die compared to their counterparts. What contributes to this problem is a lack of data. Data sources used for road safety program development in public health include local collision data, as well as health administrative data, ED visits, hospitalizations, and mortality that is often reported as not accessible to local public health practice. In addition to not having readily accessible data on individual level nor neighborhood level SES that can be used to understand the relationship between the levels of deprivation, as shown in Linda's work across the quintiles of deprivation, and injuries due to collisions. Further, the way in which we analyze data on and focusing on causal factors associated with pedestrian or vulnerable road users, or the driver of the vehicle, not necessarily the upstream factors that give us sort of the idea about the event that's causing the event due to the physical separation of the vehicle from the pedestrian or the cyclist. So how do we address road safety in public health? Well, typically we think of supporting interventions for road safety across the 3 E's of injury prevention, or how do we categorize interventions? And that is education, enforcement, and engineering. Typically, public health increases local awareness and education on road safety through community initiatives such as safe cycling programs. They produce reports on risk factors associated with collisions, including dangerous driving and of late stunt driving, particularly during the pandemic. Specifically, one area that public health is focusing on lately, and since I've been working at Public Health Ontario, is engineering. So advocating for changes to the built environment in their local communities that will reduce the risk of injury, particularly for vulnerable road users. This, of course, is supported by the 2018 Global Status Report on Road Safety, as published by the World Health Organization, where they report serious and fatal injury due to involvement in a motor vehicle collision is strongly associated with road infrastructure. Of course, improvement to the existing infrastructure is very critical to improving road safety, particularly for those vulnerable road users. The WHO report emphasizes the adoption of a safe systems approach to road safety, focusing on environmental interventions over behavioral interventions aimed at the road user. Finally, and maybe most importantly for public health, is the WHO acknowledges that public health plays a very significant role in the prevention of motor vehicle collisions causing injury, including implementing, monitoring, and evaluating interventions. Public health practitioners are charged to use an evidence-informed decision-making process, both for building a program of public health as well as advocating for road safety policy. However, this is challenged by several barriers to public health practice generally, as well as that in road safety. And this was highlighted in our recent publication. I think this was published in 2020, outlining our understanding of what the challenges are to public health practice generally, as well as specifically for road safety. The process was one where we completed a review of existing provincial standards and guidelines, existing indicators and surveillance data. We reviewed evidence briefs and any other knowledge exchange products that were available to us from local public health units. We also completed a series of key informant interviews, as well as several site visits across Ontario, asking practitioners about the strengths of public health practice, challenges, and support that they needed to do the work that they do in injury prevention, as well as in road safety. We did a data analysis that was informed by an interpretive descriptive approach, and we gathered the data into themes. We also completed a priority setting exercise to prioritize the needs that were expressed by public health practitioners. So this is a very busy slide, but one is to say that there were several themes and sub-themes that address the needs and areas of potential support for injury prevention practice as expressed by the public health practitioners, as demonstrated here. Of note, the collaboration and networking was a sub-theme to the challenges expressed in current public health practice for injury prevention. It was identified in this study specifically from those practitioners in road safety that while there is significant literature supporting effective built environment interventions to reduce collisions using that safe systems approach, The public health practitioners spoke to the complexity of supporting interventions where decision makers, or where these decisions happen in BE change, that sit across multiple sectors. So how do we do the work of road safety in public health practice in the province of Ontario? Well, the guidance in public health is from the Ontario Public Health Standards, specifically the Injury Prevention Guideline. This guideline provides direction to boards of health on the required approaches in both developing and implementing programs of public health for the constituents in the public health unit population. The guideline includes the following components. There's key public health and specific frameworks and concepts, the roles and responsibilities for the boards of health, as well as the public health programming cycle. There are what's called topics of consideration or injury mechanisms, including road safety, off-road safety, concussion, falls, and violence that are included in the Ontario Public Health Standards, as well as a set of core definitions. There are key frameworks generally for public health and injury prevention specifically that include the Population Health Promotion Model, the Ottawa Charter for Health Promotion, and specifically for injury prevention, Hayden's Matrix, and as I mentioned earlier, the 3 E's of injury prevention, or how we think of categorizing interventions specifically in injury prevention. The Population Health Promotion Model shows how a population health approach can be implemented through action on the full range of determinants of health by means of health promotion strategies. Further, the Ontario Public Health Standards, and arguably most importantly, have foundational standards, and these inform all areas of Board of Health planning and programming, as of course they underlie a very comprehensive public health approach. The 3 here are Population Health Assessment Standard, Effective Public Health Practice Standard, and of course the Health Equity Standard, as I mentioned, was a standard introduced recently into the OPHS in 2018, as shown here. This standard and guideline presents recommendations for public health practice to, well, effectively decrease the health inequities so that everyone has sort of equal opportunity for optimal health and can attain their full health potential without disadvantage or any other socially determined circumstance that puts them at a disadvantage due to their social position. The roles and responsibilities under this guideline and standard is to assess and report on the health of local population, which includes assessing health inequities and social determinants of health and employing a public health practice standard that is transparent, responsive to current and emerging evidence, and which emphasizes continuous quality improvement. The approaches outlined in the Health Equity Guideline and Standard include assessing and reporting on the health of local populations, so describing the existence and the impact of health inequities to identify effective local strategies that, of course, essentially will decrease these health inequities, modifying and orienting interventions toward a health equity lens that engages priority populations and uses what's called a proportionate universalism approach. This approach is one that is used to address the health gap or health gradient by making health actions or interventions available to the entire population, however, at a scale or intensity, as well as a delivery that is proportionate to the level of need, as well as the level of disadvantage in specific populations. Further, the approach in the Health Equity Standard and Guideline includes multi-sectoral collaboration and, of course, analysis of current policies and policy development. So just shifting gears to how all of this plays into the context of actually doing the work of public health practice in road safety. So we use the opportunity through the CHASE grant and the access to practitioners in public health to better understand what are the challenges in advocating for this built environment change that public health practitioners are doing every day in road safety. So we've pulled data specific to the public health practitioners from that larger data set, as mentioned earlier by Emily. So in brief, interview and focus group data were gathered from all of those sectors mentioned previously in Emily's work as part of CHASE, in addition to some other public health units in the province of Ontario that we were able to collect data from. So here in the next few slides, I'll be presenting on the data recently summarized, and by that I mean last week, specific to public health in the following public health units: Stewart Region, Ottawa Public Health, Montreal Public Health, Peel, Peterborough, and Calgary. So the major themes that were identified from the data, again here specific to public health, included funding, resources, the current built environment, accessible public transit, inclusive community engagement, and cross-sectoral collaboration. When we think of these data by the way they were communicated or further analyzed by factors that act as barriers, facilitators, or both to the process of implementing BE change, we found that barriers included funding, resources, the current built environment, and inequities in the built environment change process that happens within public health. And facilitators included accessible public transit, inclusive community engagement, cross-sectoral collaboration, and interestingly, connection to other health outcomes, either within the public health unit department or other departments within the public health unit. So just demonstrating some of the data that supports these themes. So as a barrier, what was predominant in these data was the resource barrier was specific to data. So here, as demonstrated in this quote from a practitioner in Peterborough Public Health, quote, "I wish there was reliable data at every local level that could be analyzed by sociodemographics to ensure an equitable display of the issue. Not only would this data be reliable, but it would be robust to support GIS mapping should this requirement be needed. It would allow us to use powerful visuals to tell the, quote, story. It would also allow us to display the equity issues of our focus area." Data demonstrating collaboration or cross-sectoral collaboration as a facilitator here from a practitioner in Ottawa Public Health, quote, "Building relationships across the organization has been critical in identifying opportunities to promote active transportation through the built environment." Another example of a facilitator of community engagement from Calgary Public Health, quote, "I believe community-led interventions work well. When politicians see community engagement, it lends weight to the obvious community desire for improvements." And finally, and interestingly, maybe selfishly for me in public health, as demonstrated here by Peel Region Public Health, connection with other health outcomes, either within the department or outside of the department, that connects their work to the work of others, was seen as a facilitator. So having dietitians that are looking at food policy in the terms of access to healthy food, as well as those that work in affordable housing or those in the built environment. So it's communicated here as a facilitator to the work of road safety when you have others working in other health outcomes. So some key messages here to end the presentation is that from these data, it's very apparent that BE is not currently designed to support vulnerable road users, particularly those that experience increased risk due to factors associated with the social determinants of health. Major barriers included funding and resources and facilitators around cross-sectoral collaboration. We're very excited to look at these data more so in the sense of teasing out what could potentially be factors to overcome the barriers in supporting the work of applying the health equity guideline, the health equity standard for public health programming across Ontario. I just thought to end on this quote that I thought was quite relevant, quote, "Large-scale built environment changes targets the entire population because making positive changes to our infrastructure to support health and safety benefits everyone." And that's a lovely quote from a practitioner in Peel Public Health. Some references from the presentation today, and I just wanted to thank you so much again for the invitation and the opportunity to chat about this really important issue.
Great, thank you, Sarah. I Thank you all our speakers. We have some questions, which I'll get to in a second, but I also wanted to draw your attention to something that Mary put in the chat about the overlay bridge changes and the community consultation, that not only is it a better process, but it, it results in a better plan, which I think was an interesting comment. Oh, so Richard Gould has asked a few questions. I think the first one is directed towards Linda. Can you comment on the possible increased risk for injury to pedestrians associated with SUVs?
Do you mind if I answer all three of his questions together?
Oh, no, go ahead.
They're kind of all... Thank you, Richard. First of all, absolutely, SUVs are associated with higher collision. Well, severe collisions for sure. There's issues around sight lines, not being able to see through the back of these large cars in cities. They're particularly a risky situation for kids because the bumpers are so high and tend to be for smaller children at the head level, so that if they do get hit, they get hit in the head or in the upper body, which is usually quite severe. So absolutely. Linking hospital data with collision data. Yes, we would love to be able to do that. Some researchers starting to do that. If we can link hospital with collision data, we have not only a better source of more severe injury, and I have to emphasize more severe injury because those are the ones showing up at hospital, but also the location, which we're missing with the hospital data. So that's something we're working towards. Dr. McPherson may be able to speak a little bit more to data linkages, but I do want to say one more thing in terms of motor vehicle collisions in COVID, because Richard said something about what's happening, asking about what's happening with MVCs post-COVID. We've just recently put in a draft report to the City of Toronto looking at trends. We don't have, we have data up until the end of 2021, and we're going to keep following it forward as part of a large grant where we have looking at COVID and road traffic injuries. This group is working on this grant together. Surprisingly, the collisions are down and they stay down, pedestrian and cycling collisions. And I say surprisingly, especially because the volumes, we don't have good volume data, but every indicator shows that the volumes are vastly up. So even the fact that if we've stayed the same with the collisions, we're still doing better because lots more people are out on the roads. The only thing that's gone up over time are non-motor vehicle collisions, cycling collisions. So most of the collisions that we're seeing are actually off-road. I think there's lots of recreational riders on multi-use trails that are getting hurt enough that they're showing up at the emergency department. So that's kind of interesting because, the perception was always that it's the on-road ones that they are the most severe, but we've seen a lot of increase in the off-road ones since the beginning of the pandemic, but overall we've seen decreases in collisions and increases in volumes. So I hope that answers all of your questions together. I don't know if Alison wants to speak a little bit more to data linkage, or Sarah, yeah, go ahead.
Just maybe before data linkage, I sit on many regional road safety groups across the province, and the report of the increase in stunt driving during COVID has been a real concern for not only obviously OPP and police, but local public health practitioners that have been taken away from road safety for the lion's share of the pandemic to work on the pandemic. And so it's sort of one of those, additional unintended consequences of the pandemic is to not be able to address what is happening in local communities around Ontario, particularly around this increase in stunt driving.
Thanks, Sarah. We have another question, but just to get back to the data linkage, if we could link the data, it would be so much better, right? If we could link the EMS data and the police data with the health services data. The problem is that usually the police for sure don't get no HIP card or no HIP number, and neither do the EMS folks always. So there's no mechanism to link them right now, which is really unfortunate because we have to make a lot of assumptions, especially around injured cyclists, that they were injured fairly close to their home, but we know that cyclists can travel far. So it would give us a better idea if we, because when we looked at the data from emergency department visits and police reported collisions, there were a lot more people in the emergency department than the police had reported. So we know that there's a lot of underreporting in pedestrian and cyclist collisions. And I think some of that may have historical roots in the fact that, you know, we've tended to blame vulnerable road users for their own injuries rather than trying to make the built environment safer, as you've heard. Karush has a question about, says thank you, he or she. In high-income districts, parents may take children to school or other places by personal car, and this may reduce the injury rate. However, in low-income districts, more children may use public transportation inevitably. Higher income districts have lower density. Therefore, this lower population may show a reduction of injuries. Okay, I think all of our speakers could answer that one. Who wants to take a first stab at it? Linda?
Okay. In terms of number one, it's actually quite interesting. In the city of Toronto, we actually found that more of the kids walk to school in the higher income areas, which was surprising because when you look at all the papers from the States, it's always the other way around. City of Toronto, again, like we've unfortunately been very focused on the city of Toronto, though some of Sarah and Emily's and Allison's work in terms of objective 3 were in some of the more suburban areas. Thing is there are a lot of very high income areas in downtown Toronto, which are easier walkable distances. We have parents who both parents may not be working, so they take the time to walk their kids to school. We had some very, very high walking rates in high income areas. Some of the outskirts, Scarborough, Etobicoke, we actually saw more people driving because the distances were longer. And some of the lower income, they may not be, a 2022 fancy car, but people were showing up more in cars in some of the lower income neighborhoods, which is really different from what you see in the States. In terms of the high income districts having lower density and low income, looking so that it looks like there's lower injury rates, we actually do our calculations per number of people living in the area. So our calculations in terms of the rates of injury does take into account that it's the higher income areas have lower population numbers. So the rates are standardized according to that. I hope that answers the questions. I don't know if anybody else has to add.
I did just want to draw people's attention that Sonia has put in the chat, and Richard mentioned too, that York district has worked with Queen's University on a project examining and providing recommendations to improve road safety. And there's a link to that report there, which would probably be very interesting for a lot of us to have a look at. I'm not seeing any other questions at the moment. Are there any other questions, thoughts? Okay. Shireen, should I send it back to you?
So I would like to thank everyone again for attending and the speakers for the great engaging presentation. This was definitely very, very helpful. And I would just like to share my screen for the next session, where is upcoming in June 8th. We have like a great list of speakers, and as you can see in the screen, the topics to be discussed on June 8th. So please tune in. It's the same time. And again, thanks everyone. And we're looking forward to seeing you in the next event. Thanks a lot, Allison, for your great moderation for the session.
Thank you. Thanks so much, everybody.
Thank you.
Thank you.
Thank you.
Okay.
Thanks for everything, guys.